Bismillahirrahmanirrahim. My affectionate students, Assalamu alaikum wa rahmatullah. In my last class, one point regarding role of peristalsis in absorption of drug was not properly mentioned. That's why I want to say something about role of peristalsis in absorption of drug. Peristalsis, onward propulsive movement, is necessary for absorption of drug from guts. For solid particle like tablets and capsule, due to when ingested, due to peristaltic movement, it disintegrates, and then granules of that disintegrated product now dissolve in the gut fluid and then absorbed by simple diffusion. So for disintegration and dissolution, then absorption, peristalsis is necessary. But if the peristalsis is more, as in diarrhea, then absorption from the gut will be decreased. So, on the other hand, if peristalsis is decreased by, as for example, in case of paralytic ileus, or by drugs like atropine or morphine, then also absorption of drug from the gut will be decreased. So for absorption of drug from the gut, optimum peristalsis is necessary. The term is optimum peristalsis is necessary for absorption of drug from gut. And peristaltic movement favors in two ways. Number one is by promoting disintegration and dissolution, and number two is by increasing blood flow. When there is peristaltic movement, optimum peristaltic movement, there is increased blood flow, and that facilitates absorption of drug. So please remember these things, that peristaltic movement, optimum peristalsis is necessary for absorption of drug from guts. Now today's topic is distribution of drugs. Blood reaches in blood. Now it can go anywhere, from brain to foot, anywhere it can go. But this is not the fact. All organs of the body is not equally supplied by the drugs. So distribution of drug in body is not equal, is not uniform, is uneven. What is the reason behind this? There are some reasons, or there are some factors which modifies this distribution process. Number one is physicochemical properties of drug. Number two is regional blood flow. Number three is binding, and number four is barriers. I am going to discuss one by one. First thing is the physicochemical properties of drug. That means lipid to water partition coefficient, lipid solubility and water solubility. We know lipid soluble drug can go anywhere. It may be distributed to brain, it may be distributed to any organ, heart, liver, lung, kidney, any organ. It can go anywhere. It can remain outside the cell, it can remain inside the cell. Its distribution is very wide. It may remain inside the cell because there is no bar for it to enter into the cell, because cell membrane is mostly composed of lipid, and lipid soluble drugs dissolve in lipid matrix and go inside the cell, can remain outside the cell. So its distribution anywhere, it more inside the cell, extracellular and outside the cell, intracellular and extracellular, but usually it remains inside the cell. On the other hand, water-soluble drug, their distribution is limited. Their distribution is mostly extracellular. But if the size of the drug is smaller than that of the pores of the membrane, then it can enter into the cell, because it can cross, the lipid matrix is barrier for them, but it can enter into the cell and come out of the cell through the pores. So its size must be smaller than that of the pores of the membrane. So its distribution mostly extracellular. Now regarding regional blood flow or cardiac output, all organs of the body are not getting equal part of the cardiac output. There are some organs of the body, according to their importance, they get maximum share of the cardiac output, like brain, like heart, like lungs, like kidney, like liver. They get maximum amount of cardiac output. Then muscles, though the bulk portion of the body is composed of skeletal muscle, they have that share. and adipose tissue, thereby subcutaneous tissue and skin, they have got least amount of share of cardiac output. So this regional blood flow also determines distribution of drug. Those areas where blood flow is more, drug supply will be more. Those areas where blood flow is relatively less, drug supply is less, and those areas where least blood flow, drug supply also least to that area. Now another point is binding. Binding means binding to the plasma protein and cellular tissue binding or cellular binding. Now when drug after absorption comes in blood, it remains in two forms. One is binding form, one is free form. It is the free form which is distributed throughout the body. It is the free form which will produce its action. It is the free form which will be metabolized, and it is the free form which will be excreted from the body. But the binding form is not distributed, is not metabolized, it does not produce effect, and it is not excreted from the body. So the binding form and the free form maintains equilibrium, and when the free form decreases, and then the drug releases from the binding form. So a drug binding capacity of drugs, it varies. There are some drugs which have got more binding capacity. There are some drugs which have got moderate or relatively lower binding capacity. There are some drugs which have least binding capacity. High binding capacity drugs are sulfadoxine, sulfamethoxazole, then aspirin, then digitoxin. Moderately binding drug like tolbutamide, then methotrexate, then warfarin sodium. Least binding drug is inulin, antipyrine. And this now drug binds with first plasma protein, and this plasma protein may be albumin, may be globulin, may be alpha-1 acid glycoprotein. As the albumin amount is more, so drug binds with albumin, maximum drug binds with albumin, and usually basic drug binds with albumin. And the alkaline drug, acidic drug binds with albumin more, and basic drug binds with alpha-1 acid glycoprotein. And hormone and iron binds with globulin. Now there are some features of albumin binding. This binding is not unlimited. This binding it has got limited capacity, and this binding is non-specific. This binding is not specific, non-selective, and this binding is competitive in nature. This binding is competitive in nature, means any drug can bind there is no single point for a single drug to bind with. Any drug can bind with any point. So one drug may bind with several points, and several drugs may bind with same point. And this binding is not unlimited. Up to a certain limit, drug will bind, and then that means it has got saturation. Further, if there is more amount of drug, then it will not be bind with, but it will remain in free form. And this binding is competitive in nature. If a drug having more binding capacity given later on, but previously given drugs having moderately binding capacity, then later on this high binding capacity drug will displace drug which have got moderate binding capacity, as a result of which moderate binding drugs will be released from its binding site, will remain in free form, and their activity will be increased as well as their toxic effect will be increased. For example, if a patient gets either tolbutamide, anti-hypoglycemic drug, or warfarin sodium, anticoagulant, or methotrexate, anti-cancer drug for a specific reason, and for other reason, if he or she needs aspirin, then what will happen? As aspirin has got more binding capacity in compared to above mentioned three drugs, so that drug will be displaced by aspirin. So if tolbutamide is displaced from its binding site, its free form will be increased, and it will produce hypoglycemia and may lead to hypoglycemic shock. If warfarin sodium is displaced, its amount, its quantity will be more in blood, and then it will profuse bleeding. And if methotrexate is released, then its free fall will be more, and it will produce blood dyscrasia. So in this way, this is competitive nature. Binding is competitive nature. Capacity is competitive in nature. A stronger drug will release lower drug, and thereby the free drug concentration of the lower capacity drug will be increased and will produce increased activity along with toxic effect. Now there are high binding drugs. There may be question. A drug having high binding capacity, this drug is good or not good, or a drug having low binding capacity, this drug is good or no good, may be asked by the examiner. You have to say, if you say directly that this drug is good or this drug is bad, no, this is not the answer. Answer should be, it may be good, it may be not good according to circumstances. In this way, as for example, a drug having high binding capacity means this drug has got high plasma T-half. It has got high plasma T-half. This drug slow and absorption is slow and sustained, and this drug is slowly metabolized. This drug its action is slow and sustained. This drug is slowly metabolized. This drug, excretion of this drug is slow. That's why its action will be prolonged, and this drug is suitable for chronic case. And as this drug is not frequently given to the patient, so patient's compliance is good. But this drug is not suitable at all in case of emergency. Because in case of emergency, we need action of drug which is immediately acting, rapidly acting drug. But this drug, as it is long acting, so it will not produce immediate effect. So it is not suitable for acute emergency. And it has one benefit is it has got no immediate toxic effect, but once when toxic effect will appear, that will be continued for long time. On the other hand, drugs having low binding capacity, low binding capacity, they are suitable for acute emergency because their absorption is quick, their onset of action is quick, so we need a quick action in case of emergency. And its half-life is short, so this drug is rapidly metabolized, this drug is rapidly excreted, so its duration of action is short, and this drug should be repeatedly administered. So patient's compliance will not be good. So this point we have to remember that more binding drug have long half-life, have some benefits suitable for chronic case, and short binding or less binding drug has got short half-life, has got benefit in case of acute emergency. So this point should be remembered. Now there is tissue binding. There are some drugs which enter into the cell, and in the cell there are some specific components in the cytoplasm or in nucleus with which drug has special attraction, and that drug after entering into their site will bind with them with that structure, some special structures of the cell, and they will remain there for long time. As for example, iodine for thyroid gland, then thiopental sodium for adipose tissue, quinine for chloroquine for melanin containing tissue like retina, quinacrine for liver, and tetracycline for bones and teeth, that is calcium and phosphate containing tissue like bones and teeth. They will go there and they will remain, they have got their binding site, and this is called selective distribution. Among the structures of the body, these structures are selective for this selective drug, so they will remain attached with them for longer time. And this type of drugs, if we need in therapy, special type of doses has to be used, like loading dose. Loading dose is, for example, in case of malaria, chloroquine sensitive malaria, we have to give chloroquine 4 tab stat, 2 tab after 6 hours, then 1 tab BD for 3 days. Why 4 tab stat and 2 tab after 6 hours? because this drug first has to satisfy the binding sites, that is retina, melanin containing tissue retina must satisfy with this drug. Then after saturation it will come to the blood and will produce its effect. If we give one tablet daily, then it will produce effect, but it will take so long time that language fails to express, because after saturation of the binding site, drug will come to produce effect, but we need immediate effect. That's why we have to immediately satisfy the binding site. Then it will quickly comes to the free form and will produce its effect. So this type of dose is known as loading dose. So in this way we can adjust the dose. Now this plasma protein level may vary from pathological condition, from physiological condition. During hypoproteinemia, the albumin level will be decreased. So drug binding will be decreased, and free fall of the drug will be more, and so the action of drug will be more. In that situation, dose has to be adjusted. And in case of kidney disease, in case of liver disease, then plasma protein level will be decreased. In case of inflammatory condition, alpha-1 acid glycoprotein will be increased. And in case of pregnancy, albumin level will be decreased, but glucagon level, albumin level is but globulin level will be increased, but albumin level will be decreased. So these are the physiological and pathological and nutritional situations where plasma protein level will be altered. So drug remains in plasma protein either in binding form and in free form. Free form is the active form, and binding and free form maintains equilibrium with each other. Now the barriers. Barriers are cell membrane is a barrier. Cell membrane, we discussed earlier that it is composed of bimolecular lipid layer interspaced in protein layer. So lipid soluble drug can enter inside the cell, can remain outside the cell, but it's mostly remain inside the cell. On the other hand, water soluble drug, they cannot enter into cell because of lipid matrix, but there are pores. Through these pores, this drug can enter. This drug can go into the cell and come out of the cell, if provided its size is smaller than the pores of the membrane. Now, most important barrier is blood-brain barrier. Blood-brain barrier is an anatomical barrier as well as metabolic or physiological barrier. This barrier is very important for the protection of the brain, which is the most vital structure which controls all activities of the body. And so drugs cannot enter cannot cross blood-brain barrier unless it is lipid soluble. Lipid soluble drug only can cross because there is no bar. But if water soluble drug cannot cross. But if some water soluble drugs or water substances which will be needed by the brain, as for example glucose, amino acid, polypeptide, they will be taken up at the cost of energy by active process. If we introduce some drugs through spinal route, then this drug may be pumped out by the choroid plexus, and there are enzymes in the meninges which can destroy the drug. So thus maintains heavy protection of the cerebrospinal axis. But if there is inflammation, then this permeability may be changed. Like penicillin normally cannot enter through the blood-brain barrier, but when there is inflammation, then it can cross. Then another, and in this blood-brain barrier, here a special layer is there, that is the layer of choroid plexus, cells of choroid plexus, layer of astrocytes of choroid, layer of astrocytes of glial cell. Basement membrane, tunica intima, media, and adventitia, and another layer is trophoblastics. There is glial astrocytes of glial cells, and this is so the membrane is imporous, cannot lipid soluble drug, only lipid soluble drug can cross, water soluble drug cannot cross because of the extra layer by the choroid trophoblastic cells of the by the glial cells, astrocytes of the glial cells, by the astrocytes of the glial cells. Now, there is another important barrier is placental barrier. Placental barrier, here is also another layer is choroid chorionic villi of the problastic cells of the chorionic villi. Here the additional layer of the Tignica adventitia, and additional layer is problastic cells of the chorionic villi. That's why only lipid soluble drug can cross, but water soluble drug cannot cross. Water soluble drug which is needed, like immunoglobulins, like glucose, like amino acid peptide, needed for the growth of the fetus, they can cross at the cost of energy, at the cost of IT process. Otherwise, other drugs will not allowed to enter, and so the baby fetus is well protected from random utilization of drug. Now, during this pregnancy is very important component of reproductive life of female, and it is divided into 3 trimesters: first trimester, second trimester, and third trimester. In first trimester, fetal development, fetal organ formation and differentiation occurs, that is organogenesis occurs, and this time is very vulnerable. If during this time mother consume drug, that drug may cross placental barrier and may adversely affect the fetal development process. That's why the drug should be avoided as far as possible during this time period unless otherwise indicated. If drug is used during this time, then it may adversely affect the fetus, and when this fetus comes on this earth as baby, will have some congenital abnormalities, and that is called teratogenic effect. Teratos means monster, and the drug is called teratogen. And during last century, about 50 decades, mid-50 decades, there was a thalidomide disaster in Germany. Thalidomide was a very popular drug used as hypnotics, and pregnant women at that time used to induce sleep by taking this drug thalidomide. But after delivery, it was noted that they delivered baby with one limb. There may be one limb absent, 2 limbs absent, one hand or one leg absent. That is named as phocomelia, or absence of limb, or seal limb, and that drug was banned. There are many drugs can produce teratogenic effect. Aspirin can produce teratogenic effect, then steroid can produce teratogenic effect, may produce cleft palate, may produce Talip's feet, may produce spina bifida. So there are so many abnormalities will be produced during first trimester. So first trimester is very vulnerable, so drugs should be avoided as far as possible, and only those drugs which is necessary to maintain pregnancy can be given during this time, like iron, like folic acid, like calcium. Now, in second trimester, drug is relatively safer in compared to first and third. But during this time, one drug is tetracycline, which can produce teratogenic effect, because during this time, bone formation process starts, and this drug has got affinity for the calcium and phosphate containing tissue, can produce harmful effect. Now, in late part of the pregnancy, just before labor, their drug should be avoided as far as possible, because there are some drugs which can induce labor, producing premature labor. There are other drugs which can delay labor, causing post-maturity. Yeah, as for example, oxytocin, argometrin, prostaglandin, quinine, they induce labor. They promote labor. They are known as oxytocics or ecbolics. On the other hand, there are some drugs like salbutamol, tarbutaline, beta-2 agonists. They inhibit contraction of the uterus and may produce delayed labor or post-maturity. Labor is a condition in which optimum time is the best time. If premature labor occurs, that is dangerous. If post-maturity occurs, that is also dangerous. And dangerous for fetus, not only fetus, but also for the mother. So during pregnancy, drugs should be avoided as far as possible unless otherwise indicated. And drug can be given by observing risk-benefit ratio. I am coming to an end of this class, but the last point is redistribution of drug. We can give an example about redistribution. The example is thiopental sodium. This is a ultra short-acting barbiturates. Ultra short-acting barbiturates because its action is very short. Its action within few minutes will be stopped. This is a drug used as for induction of anesthesia. They are not anesthetics. They will induce anesthesia, and that anesthesia will be maintained by volatile gas or liquid. And when this drug is given intravenously, due to its lipid solubility and high vascularity of the brain, drug goes to the brain completely. So its concentration in the plasma falls, and it inhibits all cells of the brain, and they produce unconsciousness. But as there is a binding site, this drug returns back due to concentration gradient and comes in the blood. So the concentration consciousness regains within few minutes. That's why it is called ultra short-acting barbiturates. Then this drug goes to the highly perfused organ like kidney, like liver, like heart. But again, there is no binding site for it, so it returns back to blood. And finally, it goes to the adipose tissue where they have got binding site. It will remain for longer time, about 5 to 10 days. So its effect is ultra short-acting, few minutes, but the drug remains inside the body for several days. This is redistribution. So the interpretation of redistribution is it will terminate the activity of the drug. So drug action can be terminated by metabolism, by excretion, as well as redistribution. This is all about today's topics, and I am giving most emphasis on selective distribution, on plasminogen binding, as well as factors modifying drug action, especially teratogenic effect. May Allah bless you. Assalamu alaikum wa rahmatullah. Thank you for your patient hearing. My next class will be on pharmacodynamics. Thank you again.